So again, good morning. Uh, this morning session is on right heart catheterization. And what we mean by right heart catheterization is we put a catheter in the right side of the heart. And we can do a number of things when we have a catheter in the right side of the heart. We can measure oxygen saturation. We can measure pressures. Um, those are some of the main things that we can do. Measure pressures, saturations, and blood flow. There are different methods of measuring blood flow or cardiac output. But the main purpose of doing right heart catheterization, we sort of divided it into two main categories, is diagnostic. We want to diagnose something, or therapeutic. We want to treat something. So the diagnostic indications for right heart catheterization. Again, if you want to look at some pressures and you want to look at the oxygen saturation, and those things are very, very important because elevated pressures in the right side of the heart will affect the right side of the proper functioning of the right side of the heart. So looking at the pressures to see if they're normal or elevated or even reduced is very important, because if someone is dehydrated, the pressures in the right side of the heart are going to be extremely low. So that's important. Patients who are in shock, right heart pressure measurements is very important, because if the patient is in shock and the right heart pressure is very reduced, then there are a number of conditions that can cause that, but you have to give the patient fluid. You have to give the patient fluid, as opposed to a situation where the patient is in shock and the pressures are elevated. That's usually due to something else. So the diagnostic indication, you want to diagnose something. You can measure the pressure and record its waveform. So not only the absolute value of the pressure is important, but the waveform, what the waveforms look like. If you have elevated right ventricular pressures or PA pressures, the patient may have a VSD, ventricular septal defect. They may have pulmonary stenosis. Pulmonary hypertension is a very large indication for right heart catheterization. Okay, and you get pulmonary hypertension, a lot of conditions. Patient may have a valvular heart problem, they may have a cardiomyopathy, or they may have lung disease, COPD. We also do what you call pulmonary capillary wedge pressure, and we'll expound on that a little bit more. But when we do pulmonary capillary wedge pressure, that is a surrogate of the left atrial pressure, which is a measure of the left ventricular end-diastolic pressure. So we can put a catheter in the right side of the heart, specifically in the pulmonary arterial system, and go into the capillaries. We wedge the catheter in the pulmonary capillaries, which is really looking. Remember, the capillaries will eventually lead to the pulmonary veins, and the pulmonary veins enter the left atrium. So those pulmonary capillaries are really a reflection of the left atrial pressure. So when we say pulmonary capillary wedge pressure, it's a surrogate of the left atrial pressure. Because if we can't get into the left side of the heart, the next best thing is to put a pulmonary capillary wedge pressure. Pulmonary capillary catheter into the pulmonary capillaries and get a wedge pressure. Okay, so that's very important. Then oximetry. So we can measure the oxygen saturation in the right side of the heart, and that will help us to diagnose certain shunts, and not only that, but to do shunt calculation, the so-called QPQS, because think about it. If you have an ASD, then we know that the oxygen saturation in the right side of the heart is much lower than that on the left side, of the order about 75%. So the oxygen saturation, the right side of the heart is roughly about 75%. If there is an atrial septal defect, you're going to have mixture of the oxygenated blood from the left side going on the right side. So we talk about the oxygen saturation step up. Oxygen saturation step up. The oxygen level in the right sided chamber is going to be elevated. So if you have an ASD, the oxygen saturation in the right atrium is going to be elevated, and also in the RV. If you have a VSD, you get a much higher increase in your oxygen saturation in the right ventricle, and then a PDA, the mixed venous oxygen. So just think about it. If you have a defect, because you're going to have the admixture of blood, the oxygen saturation on the right side of the heart is going to be increased a little bit. So these are some of the main diagnostic indications for your right heart cath. Again, remember that we use a pressure catheter, the so-called Swansgan's catheter, to do a right heart catheterization. And the reason for that, it has all these parts which are very important, as we have shown before. So it's a catheter, so it's a long tube-like structure. You have what we call the distal lumen, which is open, and you can inject fluids. You can put a wire inside there, and then just before you get to the distal tip, you have the balloon. And this is the balloon. We inflate the balloon and wedge it in the pulmonary capillary. So this lumen looks at just the pulmonary capillary wedge pressure, which is a surrogate of the left atrial pressure, which is a reflection of the left ventricular end-diastolic pressure. So this is the portion that we wedge. We blow the balloon up and it's held in place in the capillaries, and then we can measure the pressure. Again, you have the thermistor, which allows us to measure. One of the methods to calculate cardiac output is we inject cold fluid, relatively cold fluid in the catheter, and we are able to measure flow. Okay, so the thermistor, and then proximal injection port. So these are the different hubs. Okay, so this is the hub. When you inject air in this hub, the balloon inflates. So balloon inflation valve, and then this hub is the distal lumen. So you can connect this distal lumen to your monitor, and then you'll see the pressures. You get a reflection of the pressures. Okay, so this is a distal lumen, and you can put a wire inside this to make the catheter a little bit stiffer and to sort of guide the catheter to where you want it to go with so-called Swansgan's wire. So you can put that, and then this is a thermistor. You connect this to your device to get your cardiac output. And then this is a proximal injection port. So this, when you inject something through here, it comes out right there. Okay. And this is the actual catheter itself. Okay, so the actual catheter looks like this. Okay, the balloon is right there, distal tip, and and then the different hubs. Okay, this is the syringe that we put up about 1.5 mLs of air, and we put it in the balloon port to blow the balloon up, wedge the balloon in place. So it's Swansgan's catheter. Now, when you're going to do your catheterization procedure, especially if you're going to do it to the groin, you need to know the basic anatomy of the blood vessels and nerves relationship in the groin. The femoral vein is a very common site that we will do these right heart catheter from. But any venous system that can you can end up into the right side of the heart, you can use that venous system. So you can do the jugular, you can do the brachial, as long as it ends up into the right heart, you can do it. But in the groin, this is the basic anatomy. We have what you call the inguinal ligament. So the inguinal ligament comes from the crest of the iliac bone, and it comes to medially to the pubic bone. So this is the inguinal ligament. Below the inguinal ligament, you have these structures. You have vascular and nerve structures. So the first one, medially, this is the vein. Then you have the artery, and then you have the nerve. So you have to know this relationship when you're doing a catheterization, because you want to enter the vein. You don't want to, when you're doing a right heart catheterization, you want to enter the femoral vein, not the femoral artery. If you're doing a left heart catheterization, then you enter the femoral artery, which allows you to get to the left side of the heart. But if you want to get to the right side of the heart, you have to enter the femoral vein. Okay. So the femoral vein is going to be the vessel that is most medial. So you can't feel the vein, but when you feel the arterial pulsation, when you put your fingers there, you feel the arterial pulsation. You know that's an artery, so you want to go a little bit medial to that. Okay, so once you go medial, you'll get the vein. Okay, you don't want to puncture the artery, because then you're going to be spending a long time holding the pressures. Okay, and then the most lateral structure is the nerve. You don't want to puncture the nerve, because the patient is going to have a lot of pain. Okay, so this is the relationship of the different nerve and vascular structures. The most medial one is the vein, followed by the artery, and then you have the femoral nerve. Okay, and you want to do your puncture just below the inguinal ligament. You don't want to go above the inguinal ligament, so you want to go a little bit lower. Okay. When you're doing your puncture, you're going to use a needle. You're going to use a needle because you want to enter the femoral vein, and you're going to position your needle about 45 degrees to the horizontal, and you're going to you're going to puncture the vein. You don't want to go through, you don't want to go to the posterior wall of the vein. You want to stay inside the vein. So what you can do is, if you have a syringe, you can slightly advance the needle until you get blood, because you don't want to puncture straight through the vein. So your needle inside the vein, once you pull back on the syringe a little bit and you advance, you'll see blood coming, and you'll see it's a dark blood as opposed to bright red blood, which suggests that you're in the femoral artery. So once you're in the vein, you take off your syringe, and then you're going to put your guide wire. Okay, we talk about a guide wire. So you insert your guide wire through the needle. Okay, so this is a guide wire. So guide wire is very small. It's very flexible, and it should be something that's non-traumatic. It should have, preferably a curved end, so you don't want to puncture the the vein. So you advance your guide wire through the needle into the vein. Okay, so the guide wire. So you remove your needle now, and then over the guide wire you put a plastic tubing, and we call that a sheet. So your sheet looks like this. Okay, so it's a, we have an introducer in the sheet, and once you put, so you're going to put this over the guide wire. You put your introducer sheet over the guide wire, then you pull out, you remove the introducer. So all you have is this plastic tubing, and there's a side port, so you can remove blood, or you can, add fluid or whatever. So you have a side port right there. Okay, this is your side port, and then there's just this plastic tubing you're going to leave in place. Then through your sheet, you can put your Swan-Ganz catheter. So you put your Swan-Ganz catheter, and you're going to do this on the what we call fluoroscopic. You do it on the fluoroscopic, so you can see what you're doing. So you advance your Swan-Ganz catheter into the venous system straight up to the heart. And if you remember your anatomy, the inferior vena cava comes into the right atrium, superior vena cava also comes into the right atrium. Then you have your tricuspid valve. So you'll move from your right atrium across the tricuspid valve into the right ventricle. You have your pulmonary valve right there, your pulmonary trunk, the right pulmonary artery, and the left pulmonary artery, which goes to the respective lungs. So that is how you do your right heart catheterization. And you have to take care that you don't traumatize the vascular system. So you always try and look and see what you're doing. Now, remember what we said, the indications for doing these procedures to get pressures, to get, because getting the pressures will help us to make certain diagnoses. And then we also get saturations, that is the oxygen saturation in the blood, which will help us to determine if there is any shunts, any defects in the structures. All right, so when we get into so you're going to enter the right atrium. Okay, so whether wherever you got your access, you may get your access from the brachial, or you may get it from the femoral, or you may get it from the jugular. You're still going to enter the right atrium. So when you enter the right atrium, you'll get pressures looking like this. We call it the right atrial pressure. The normal right atrial pressure should be, it's usually between 0 and 8, okay? And you'll hear the talk about the A wave, a X descent, a V wave, and a Y descent, okay? So we'll talk a little bit more about that. But when you enter when the catheter is in the right atrium, you'll get your right atrial pressure tracing. The right atrial pressure tracing is comprised of a number of different waves and descent, however. And then when you advance the catheter now, so the catheter now advances into the right ventricle, you get a pressure waveform looking like this. You're going to get a systolic component and a diastolic component. So this is what your RV pressure tracing looks like. And usually the systolic is between 20 and 30 millimeters mercury, and the diastolic is about 0 to 8 millimeters mercury. But this is what your right ventricular pressure tracing looks like. It looks similar to your left ventricular pressure tracing, but the pressures are much less. You have a systolic component and a diastolic component. And then when you advance the catheter now into the pulmonary system, pulmonary trunk, you get what we call a diastolic step up. So you don't have to, once you're familiar with your waveform, you know that you're in the pulmonary arterial system, because you're going to move from a curve looking like this, or a waveform looking like this, to a waveform looking like this, where the diastolic pressure is now elevated. Okay, the systolic pressure is going to be roughly about the same as your RV systolic pressure, but the diastolic pressure is going to be higher. So in the pulmonary artery, uh, this is the waveform you're going to get. You get a diastolic step up. You see, in the RV tracing, the diastolic pressure was about 0 to 8. When you get into the pulmonary artery, the diastolic pressure is about 8 to 15. Okay, and then when you get what we call the pulmonary capillary wedge pressure, you have to advance the catheter even further out. And then remember, now your arteries are going to divide it and give you arterioles. Your arterioles is going to divide and give you capillaries. Okay, and the capillaries is going to go to the lungs, um, and the capillaries actually give rise to the pulmonary veins, okay, which drain into the left side of the heart. So when you wedge your catheter, so this is, you wedge your catheter, you blow the balloon up and you wedge your catheter into the capillaries, you're actually looking at the left atrial pressure, which is a measure of the left ventricular end diastolic pressure. And then the waveform that you're going to get is similar to your right atrial waveform. Pressures are going to be a little bit higher because the pressures on the left side is a little bit higher. But you're going to get your A wave, your X descent, V wave, Y descent, okay? So you have to know the different pressure tracing. Right atrial pressure tracing, because that's where you're going to get to first in the heart. You cross a tricuspid valve, you get into the right ventricle, right ventricular pressure waveform, and then you advance the catheter into the pulmonary trunk, or one of the pulmonary arteries, right or left, and you get your PA pressure waveform. You get the diastolic step up. Systolic pressure is usually roughly the same. And then when you advance the catheter further, you get your pulmonary capillary wedge pressure, which is a measure of the left atrial pressure. Okay? So if we were to separate out these pressure waveforms, okay, so again, in uh, the right atrial pressures, okay, it's made up of a different components. We talk about a wave, we talk about a C wave, we talk about a X descent, and we talk about a V wave and a Y descent. We'll explain what these means. But basically, when the catheter enters the right atrium, you're gonna get these type of a waveform looking like this, a pressure tracing looking like this, and it has different components. And then when you get into your right ventricle, you get your diastolic pressure, systolic pressure, your diastolic pressure. Okay, this is what the right ventricular pressure tracing looks like. Your pulmonary artery waveform, you get your diastolic step up, remember? So the diastolic pressure is going to be higher in the pulmonary artery than in the right ventricle. And then when you get to your pulmonary capillary wedge pressure tracing, it looks similar to the right atrial pressure tracing, but the pressures are elevated. You're going to get your so-called A wave, your X descent, V wave, and Y descent. Okay, and of course, your waveform in the left ventricle. We're not doing that today, but so what are these A wave, C wave, X descent, V wave, and Y descent mean? What's the meaning of those things? So if you look here, your ECG is on top, and you get your different pressure waveform. So in the right atrium, we get the A wave is actually so the A wave is actually right here. Okay, it's in green. So the A wave is actually due to atrial contraction. Okay, because the ECG is on top, and this is right where you have your P wave, which is due to atrial contraction. So the A wave is due to atrial contraction, and then the C wave is a little hump just after the A wave, and your C wave is so. Remember, this is pressures in the right atrium. The catheter is in the right atrium, and we're measuring the pressures. The C wave is due to the protrusion of the tricuspid valve into the right atrium. Remember, in systole, the tricuspid valve is closed, but the left ventricle is contracting. So it's going to push the tricuspid valve up a little bit, and that is reflected as an increased pressure in the right atrium. So C wave. And then after the C wave, you get what we call your X descent. The X descent is relaxation of the right atrium, because in ventricular systole, the right atrium is being filled with blood. Okay, so the X descent is due to the relaxation of the right atrium. So the pressure falls because it's relaxed, and you get a downward pulling of the tricuspid valve. Then after, so you have your A wave, your C wave, your X descent. Then after that, you get what we call the V wave. Now the V wave is due to RV contraction. Okay, the V wave is, so they remember the RV is contracting. Okay, so from the onset of the QRS to the end of the T wave is what we call systole. So when the RV contracts in systole, remember the tricuspid valve is closed. So that's going to be reflected as an increased pressure. That's going to be reflected as an increased pressure in the right atrium. Okay. Then after, so at the end of systole, then the tricuspid valve opens and the blood flows from the right atrium into the right ventricle, and you get the so-called Y descent because the pressure falls. Okay, so the components of the right atrial pressure tracing, you have your A wave, due to atrial contraction, C wave, which is due to the upward push of the tricuspid valve into the right atrium, so the pressure increase. Then the right atrium relaxes. You're talking about ventricular systole, but the right atrium relaxes, so we have our X descent. Then the RV contracts. When the right ventricle contracts, it's going to push the tricuspid valve up into the right atrium, so the pressure increase. Then you now get into diastole, where the tricuspid valve opens, and you'll have your so-called Y descent. Okay, and then the process starts all over again. Your A wave, your C wave, your X descent, V wave, and Y descent. So it's important to know these components, because different disease states are going to affect, the different waves. So you're going to get the same thing when you do your pulmonary capillary wedge pressure. You advance your catheter into the capillary system, and you're going to look at the left atrial pressure. So you have the components of the pulmonary capillary wedge pressure is going to be similar components. However, the pressures are going to be a little bit elevated. So your A wave, again, so your ECG is on top, okay? And so you have your A wave, which is due to atrial contraction, your V wave, which is due to protrusion of the mitral valve into left atrium. So we're on the left side now. So the V wave is due to the protrusion of the C wave is due to protrusion of the mitral valve into the left atrium. Then your X descent is due to relaxation. Your X descent is due to relaxation of the left atrium. And then your V wave, when the LV contracts, is going to push the mitral valve upwards. And then your Y descent is when the mitral valve opens. So similar explanation for the right and the left atrial pressure. The left atrial pressure is going to be higher. Okay? Remember, the pulmonary capillary wedge pressure is is a reflection of the left atrial pressure, which is a reflection of the left ventricular end diastolic pressure. So if you were to, so if we do our pulmonary capillary wedge pressure tracing, and you use your Swanson's catheter to do that, you're going to get a waveform looking like this. But if you were to advance a catheter in the arterial system into the left atrium and you were to record that, they look very, very similar. And that's, you expected that. So this is your left atrial pressure tracing. Okay, left atrial pressure tracing. So the pulmonary capillary wedge pressure tracing and the left atrial pressure tracing look very, very similar, because I mean, you expect that, because your pulmonary capillary wedge pressure, you put the catheter right in the catheter in the capillary system, which looks at the left atrial pressure. So you expect the waveform to be similar. There's a phase shift, however, when you're doing this. There's a phase shift, but the waveform look very, very similar. Now, some normal values, but you have to know normal values before you can start making diagnosis. So again, you have the right side of the heart, left side of the heart. The saturation in the right side of the heart is roughly about 75%. So if you were to take blood samples from the right atrium and you analyze it, the saturation is about 75%. And similarly, the right ventricle, and similarly the main pulmonary, the pulmonary trunk. Okay, saturation is about 75%. So remember, the blood goes to the lung to become oxygenated. So when the blood is oxygenated and it travels to the right atrium, it should be almost fully saturated with oxygen. So the saturation of the blood going to the left atrium is above 95%, very high. Similarly, in the left ventricle, above 95%. And then in the aorta, okay? So just imagine if you have a defect, atrial septal defect, you're going to have rich oxygenated blood mixing with your desaturated blood. So the oxygen saturation in the right atrium is going to be increased. Okay, so if you see oxygen step up along your right atrial structures, then you can make certain assumption, because if the oxygen step up occurs in the right atrium, then you can say, well, there is a atrial septal defect, or you may have an anomalous pulmonary venous return. That is, your pulmonary veins are draining into the right atrium. So you can make that assumption if you have oxygen step up right here. As opposed to if you have oxygen step up in your RV, you can make certain assumption that you have a defect in the ventricular septum. And then for a PDA, you're going to have oxygen step up in your pulmonary artery, okay, for a PDA. So you have to know your normal pressures, and you have to have an idea of your saturations. Okay. Again, remember, the pressures on the right side of the heart is lower than the pressure on the left side. Okay. Right atrial pressure, 0 to 8. RV pressure, systolic, up to 25. Diastolic pressure is the same thing as right atrial pressure usually. Your PA pressure, you're going to get a diastolic step up. So if this is your RV pressure, then your PA pressure is usually similar systolic pressure, as long as there's no obstruction to the right ventricular flow tract. But your diastolic pressure in the pulmonary artery is going to be higher than in your RV. Yes, so-called diastolic step up in pressure. Okay, and you can see that on the waveform. So when you do your pressure tracings, you can see that, and that is all right. So those are some normal values, and it's, doing a normal right